How to review a blood smear, March 10th, 2015. First, a disclaimer. This information is intended for medical laboratory scientists and physicians who understand that medical information is often imperfect and must be interpreted in the context of a patient's clinical data using reasonable medical judgment. This lecture should be viewed as a supplemental educational material and not be used as a substitute for standard training and procedures. Please follow the standard practices and procedures of your local institution. So the purpose of this talk is to present a standard method of evaluating blood smears to maximize diagnostic findings and minimize errors. Peripheral blood smears are one of those situations where there are a whole bunch of different findings that you sort of have to integrate, put everything together. And sometimes if you focus on one finding too early or only one set of differentials really early on, you can totally miss the big problems. So first step, before you do anything, verify the patient information. Make sure that the patient's name and other identifiers on the slide match the name and identifiers on the paperwork. Example, if you have any sort of CBC or diff printouts from the machine, make sure that the patient name on that matches the slide. Also make sure that all your paperwork matches, like say you have multiple printouts, make sure they all match. Sometimes you have a different cover sheet, make sure the cover sheet matches the diff. And this will save a lot of problems. You don't want to be presenting, wrong data on the wrong patient, or sometimes you can get sort of further down the list and you suddenly realize you're looking at the wrong slide and you've just wasted a bunch of time. So yeah, both of those scenarios are not good. So always verify patient information on the slide, make sure it matches the paperwork. Next, review the CBC and automated cell differential. There is a temptation once you get peripheral blood smear review to just go ahead and look at the slide right away and ignore everything else. But resist that temptation. Take a deep breath and evaluate the CBC data. So look at the white cell count, the hemoglobin and the platelet count especially. And it does matter in terms of assess the magnitude and the number of abnormalities. So usually the more one value is abnormal, the more likely you're going to be finding a significant finding, and the more number of these. Like for instance, you might be more likely to have a significant abnormality in a patient who has abnormal white count hemoglobin and platelet counts, rather than just a single one, like say they have a abnormal hemoglobin. And same thing with the degree. So just a mild leukocytosis is not as worrisome as a severe leukocytosis or a severe leukopenia. Next, examine the automated cell differential count, where you can get an idea of what, in general, the machine is thinking the cells are. You can note any flags, like immature cells, things like that. Review the manual differential counts done by other people if that's available. Sometimes you're not the first person to be looking at this, so you can see, get an idea of what other people think that the differential looks like. And then form a very tentative differential diagnosis based on these findings. I don't want to get too much into that here, but you, once again, don't want to be jumping to any conclusions, but you sort of want to have a general idea, what you're looking for. For existence, if you're seeing like an anemia and a thrombocytopenia in the CBC and diff, you just want to say, yeah, I want to make sure I'm going to rule out a TTP, DIC, microangiopathic hemolytic anemia, something like that. Or you say, oh, the white count's really high, I'm definitely going to make sure I'm going to rule out infection, CML, acute leukemia. And then, and once again, that sort of helps you note special areas requiring attention. So if the white count's really high, you want to, and there's an immature flag, you want to make sure you're assessing the white blood cells properly. Next step, pick up the slide. So all of these things so far, you haven't looked at the slide yet. Make sure you pick up the right slide, right patient identifier, and start at low power. So once again, you're trying to stop yourself from jumping to conclusions. So you can start at a low power, 10x if possible. Scan the slide to get general confirmation of the CBC information. Example, just if the white count was really high in the paperwork, make sure that it sort of looks the same way when you're looking at low power on the slide. And this is another opportunity to catch, if for some reason you didn't verify the identity of the patient, you can sort of catch this error here, hopefully. Before you get any further. For example, if the CBC showed a really high white count and you look at the white count on the slide and it looks normal, just make sure you're looking at the right slide. And then at this point, you can start looking for specific things. First, assess for large platelet clumps at the feathered edge. Sometimes you can have really severe platelet clumps, so you really might not notice them inside the slide, but at low power, when you look at the feathered edge, they're really obvious. Assess for red blood cell suprastructural abnormalities like rouleau cold agglutinin. These are really easy to pick up, and it's always good to think about them. Next, assess for a cryoglobulin. So you'll see like these big or small blue blobs in the background at low power on the peripheral blood smear, and they're really easy, or they're really easy to miss if you start going to high power and you really don't think about it. And then finally, take a little while to scan for low frequency, high significance events. For example, blasts, atypical promyelocytic hour rods. And you can sort of time how long you look for this, depending on the scenario. For instance, if you have you're looking at a young patient with pancytopenia, you're going to spend longer looking for atypical promyelocytes than you would in sort of like a normal white count and sort of preliminary differential scenario. Next step, go to higher power, examine the platelets for small clumps, which you'll pick out at this point, and look, make sure they're properly have nice alpha granules are purple. Examine their size, for example, giant platelets, a lot of or lack of giant platelets in a patient with thrombocytopenia. Usually I pick out platelets to do these first, just because it's really easy to not think about them at this power. Next, evaluate RBC morphology. And the things I always explicitly think to myself are make sure that you're looking for spherocytes and schistocytes on everyone. And especially spherocytes, for some reason that's one thing that people often miss, especially in neonates. There are a lot of wacky findings in neonates, but people will miss the numerous spherocytes for the hemolytic disease of the newborn. That's happened a decent number of times. Next, assess the white blood cell count and morphology. So just get a general differential in your head. Don't need to do anything specific. For example, there look like there are going to be a lot of blasts here. It looks like blasts are moderately increased, or a lot of mature leukocytes. Just sort of get an idea in your head. This is the time to ponder, what kind of cell is this? So if you start seeing weird-looking cells, this is the time to sort of think, what kind of cell is it? Can compare to other cells and sort of determine what you're going to be calling these cells on your final diff. And then finally, as far as going to the highest power, you're working your way up to go to 100x, and you can assess for RBC intracellular abnormalities like Howell-Jolly bodies, malaria. Assess for white blood cell intracellular abnormalities like bacteria, and this step can be done at 40 or 50x if you're comfortable with it, but otherwise you can do it at 100. The amount of time you spend on this step can be brief, but can be longer in situations where there's an increased prior probability of finding an uncommon abnormality. Like if you'll look longer for bacteria and white blood cells if there's a significant leukocytosis, granulocytic left shift, and toxic granulations than you would in a patient with a normal white count. And then last, you'll perform a manual differential, and then do it whatever magnification you feel comfortable, and then it shouldn't take too long at this point since you've already decided how to categorize all the cells, or at least most of them in the prior steps. And the way doing this sort of resist this temptation to grab the slide and just do the manual differential and then sort of work your way backwards from there. And then at this point, integrate the CBC and diff findings. A few examples, for instance, if you have an anemia, thrombocytopenia, and schistocytes, you think, could this be a possible microangiopathic hemolytic anemia like DSE or TTP? Some anemia and spherocytes, possible immune-mediated hemolytic anemia, mostly mature granulocytic leukocytosis. Consider infection versus CML, and lots of immature atypical cells. Could this mean acute leukemia, circulating lymphoma, various other things. And then last, integrate the lab findings with the clinical history. So at this point, you have your sort of differential based on your review of the blood smear, and look the patient up in the electronic medical record and see how it correlates with the clinical history. And then finally, a summary of the procedure. Check to make sure you're looking at the patient's smear. assess make sure you're looking at the correct patient smear, assess the CBC and automated cell differential counts, come up with a preliminary differential diagnosis, do a low magnification assessment, do a high magnification assessment, do your manual cell differential, and then finally integrate the results. And that's it. Thanks.